In this video, we're going to be talking about the rashes that also have scales. So what you need to do is identify the location of the rash on the body and then what the scale looks like. Let's go through each disease one at a time, then compare them all at once. The first is seborrheic dermatitis. The path here is an autoimmune disorder in response to a fungus. And this particular disease goes after the areas that have sebaceous glands. These are going to be the hair-bearing regions. And where you're going to see this come up on the test is a picture of someone's face. So what you're going to see is a rash, and it's going to flake. And you're going to see a picture of a face. And where there is hair, there's a rash. Where there's no hair, there's no rash. So what you'll see is a person who's got redness and flaking of the eyebrows and the scalp, but then not on the forehead or the cheeks. And that's going to be seborrheic dermatitis. The diagnosis is clinical, and the treatment is just like dandruff, selenium shampoo. You get rid of the fungus, you get rid of the autoimmune disease. You're going to see this in pediatrics in the way of a cradle cap, where baby gets a rash wherever his cap is. But really you're going to identify this in an adult by on a picture that's zoomed in on their forehead, scalp, and eyebrows, and the hair-bearing regions are involved. So the next one is psoriasis. And psoriasis comes up a couple of times in this class, and here we're actually going to talk about the rash. Psoriasis is an autoimmune disorder, and it has something to do with T helper cells. That's as far as we're sure of, so you don't have to remember the different numbers. That's for step one. What happens is you have an abundance of keratinocytes, particularly in the stratum corneum. And what you get, and this is how you're going to be able to identify this on the test, what you get is an erythematous patch. And on that erythematous patch is going to be a silver scale that bleeds when picked. Look for it on the extensor surfaces and the gluteal fold. It can be elsewhere, but they're probably going to show you a picture of the wrists or the elbow. It's going to be red and then have a silver scale on it. If you see nail pitting, that is a picture zoomed in on the nail bed with little holes in it, that's psoriasis. And oncholysis, that is the separation of the nail from the nail bed, also indicative of psoriasis. Now you don't have to do anything to diagnose psoriasis, but look at it. It's a clinical diagnosis. And while treating psoriasis gets a bit more complex, what I want you to take away from this lecture is that the first line therapy is UV light. And the second treatment is topical steroids. In real life, it gets much more complicated, and you start talking about the anti-TNF alpha inhibitors. And while that's true, that happens, you should remember UV light and topical steroids. And then a couple things you want to keep in the back of your mind going for 270. If the question has some risk factors for lymphoma or a personal history of lymphoma, you should biopsy the lesion to rule out lymphoma. It's not routine, but if they're throwing lymphoma and psoriasis together at you, go ahead and biopsy. And lastly, if you have joint symptoms, consider the seronegative arthropathies. The next one is classic for the description and the picture, and so it's really easy to make a vignette about this one. Pityriasis rosea. The problem is we don't really know what causes it, and honestly we don't care because it's self-limiting. And what you're looking for is the Herald patch. In light-skinned races, this is going to be salmon-colored, usually oval, very well demarcated. In darker-skinned races, it's going to be hyperpigmentation. You see that herald patch. It's one spot, and then subsequently more pop up, and then they begin to scale. So you can make the diagnosis just based on that salmon-colored, clearly demarcated patch without the scale. Once it scales, then you have a trailing scale. What that means is the scale never quite gets to the end of the patch. So you'll have this discoloration and a scale on it, but the scale will never reach the edge. That trailing scale is pityriasis. And this disease spares the palms and soles. If you see this exact lesion and it involves the palms or the soles, you should be giving consideration to syphilis. This on its own is a clinical diagnosis. Unless you have a suspicion, risk factors, or palms and soles, you don't have to get the RPR, but keep that in your back pocket. The question may ask you to rule out syphilis once you make the diagnosis. And since it's self-limiting, you don't have to do anything for it. We're going to finish now with lichen planus, another disease we don't really know what causes it. We do know what it looks like. It's going to be a purple papule. It's going to be raised. You're going to be able to feel it. And on top of it, it looks like it's scaling, but it's not really a scale because you're going to have this lacy network of white lines. So it looks like a scale because it's raised and it has like this shiny appearance because of the lacy network, but really it's not a scale at all. The diagnosis is clinical, and the treatment is topical steroids. You can use an adjunct UV light, but what I want you to remember for this lecture is UV light is used in psoriasis and then topical steroids. Topical steroids is used in lichen planus, then UV light. But if you see this, keep an eye out for a new medication, and this is where you get the 270. If they mention a medication change, it might be medication induced. And the ones that are classic for this are going to be the ones you use all the time. ACE inhibitors, thiazides, loop diuretics. So if you start a new medication and then get a purple papule, think lichen planus. Okay, let's run through them one at a time, highlighting. Seborrheic dermatitis, zoomed in picture of the face, eyebrows and scalp are involved, but not the rest of the skin. Treat with selenium shampoo. Psoriasis, extensor surfaces, erythema, and you're going to have a scale that bleeds when picked. Look out for nail bed, any type of separation of the nail or a hole in the nail, got your diagnosis done. Pityriasis has the herald patch and then a trailing scale, rule out syphilis, and lichen planus is that raised papule with that white lacy network of white lines on top. That's the diseases that scale.